And how do you balance that with the negative effect it has on everybody else in society? I mean, like LA, San Francisco, Portland, Seattle, all these cities are fucked right now because of. I would say harm reduction policies have played a great role in how badly those cities are doing right now. So, how do you balance that stuff?
Let's go.
Welcome to Citizen. We got a special guest today, Dr. Timothy Vermillion. You are a therapist, psychiatrist, CSW, so on and so forth. I don't even know what all the words are these days because since sometime in the mid-2000s, there's been a lot of overlap between neurology and psychology. Like a neuropsychiatrist is now kind of a normal thing. We'll get into that later. I'm very curious about the field. But before we do, get into yourself a little bit. Tell me about yourself. Where'd you come from?
Well, thank you for having me, Dan. And I'm not a psychiatrist. I have a doctorate in social work, and that's kind of the top of my credentials there. And then I have 3 other masters and a bachelor's as well.
What are those in?
I have a bachelor's in psychology, sociology. That was my undergrad. And then I went on to get my master's of social work, my master's of education, my master's of digital marketing at Rutgers Business School, and then my doctorate of social work.
Okay. And where are you from originally?
Well, I was a Coast Guard brat. I was born in Virginia, but we moved around a lot. So I lived in Florida, Alabama, Texas, and then we always came up to New Jersey because we had family up here and we spent all our summers up here. So that's where I ended up after I was about 8 years old.
And where did you prefer the most, I guess, as a kid?
I would say what I remembered most was Texas. I was kind of young back then, but Texas, Corpus Christi is where we were. So we got to go down to the beach and stuff. And that was the fun time.
I've never been to Corpus Christi. I don't even know where it is. I've lived in Texas for years. I have no idea where anything is. Like I know where the major cities are, but GPS has completely ruined my ability to know where things are now. But anyways, so your mom or dad was in the Coast Guard?
Well, they were both in the Coast Guard at one point. That's where they met. But my mother left the Coast Guard when they started to have kids, and my father stayed in.
And what was...
and he was a pilot.
Okay, so when you say pilot, though, well, I guess driver would be the other one. So they have boat drivers and they have helicopter pilots.
He was a helicopter pilot.
Okay. I don't know why the Coast Guard insists on calling them drivers of boats. I think they just want to make everybody else feel bad. But at any rate, so what made you decide to get into the field of social work?
Well, on the social work side, I was in my undergrad in my psychology program. We were doing field work, so we'd go out and do working with different organizations, and I was working with like a Big Brother type organization at the time. And some of the staff that was working in that organization were social workers, and they asked me what I wanted to do, and I'm like, I want to do therapy. That's what I want to do. I want to be a therapist. And so they were kind of like, well, if you go psychology, it's going to take longer, and you might not get as many jobs. But if you go ahead and go social work route, you'll be able to start working sooner, and you'll be able to kind of compete with psychologists in the same arena.
And once you make that decision, I mean, you've got a litany of degrees there. So, like, what was the process? I assume you were in practice already before you got maybe the marketing degree or something like that, right?
Sure. Yeah. So the process was I was doing counseling, and I've been doing counseling a lot. Now I want to kind of teach it and to provide that information to other therapists, especially in terms of my passion, which is the military. I've been in the military for over 24 years, almost 25 next month. So that's kind of my niche. And so I'm trying to figure out better ways of being able to present that information and pass that information along to other therapists, whether they be social workers, psychologists, family therapists, whatever it may be.
Okay.
And that's why I went and got these other degrees.
Well, frankly, I think that there isn't a whole lot of, so a bit on my side, I get out of the military and I do, I'm doing private security, mostly like emergency management, bodyguard work, workplace violence, stuff like that. And at the same time, I'm getting a master's in Homeland Security from Penn State. And then I go work for the federal government for a while. And I'm doing I'm aggregating data to look for criminal patterns, basically, in the immigration system. And one of the things that I found is that because I left there to go work in the marketing department at Black Rebel Coffee, and what I found was that marketing is basically just kind of tapping into human psychology a little bit. In some cases, exploiting it, I guess. I wasn't a big fan of exploiting it. I just like to, there's different ways to go about it. Throwing a trawl line out into the river where a bunch of people already are, I think, is a noble way to go about it. Exploiting people's psychology to get them to come to where you are is quite a bit different. I think that's kind of fucked up, to be honest. So we tried not to do any of that. But there's a lot of the reason I said that is because there's a lot of overlap between marketing and psychology, really. So it makes sense that you would do both.
Yeah, it all fits together. The social psychology aspect of things, how you can use even reciprocity or something like that to get people to kind of follow you along a little bit.
Sure.
And then for education, it's still learning theory and everything else kind of goes along with the same type of psychology. So it all fits together.
Sure. Yeah. I mean, I liked. I'm not particularly religious, but I enjoyed studying religion for the same reason. Looking at 3,000 or so, 3,500 years of people trying to figure out their purpose, the purpose of their existence, even, right? And what they should be doing with it is very interesting to me. The way people think, the way that we construct the way that society at large constructs an epistemology, the way that we construct what our personal identity is and stuff like that, and the way those bounce back and forth off one another is super interesting. And I think it leads into some pretty practical ways that we can treat some of the issues that modern men have, especially not just veterans. I think it spans out well outside the veteran community. It just our community is kind of more in focus, but I think that this is a pretty widespread problem. Now, you work with vets a lot. You do something that a lot of people have probably heard of, EMDR. I don't know if they know what it is. Can you, before we get into the specifics and stuff, can you tell me about the overall landscape of the type of dude you're running into out there? What's their issue?
Sure. So really, I mean, my focus is mental health, PTSD, mostly trauma-related stuff. And as we kind of move forward and try to reduce the symptoms and try to get them to find purpose, as you're talking about before, and kind of get on with trying to figure out how they're going to maneuver in their life and kind of move on to the next step in their careers. Those are the things that I'm looking at. On one side, I'm also looking at harm reduction also because we want to make sure that they're not only getting what they need mentally, but also physically. So there's a lot of assessment that's done in order to make sure that we see them as a whole person. So there's actually a term now called whole health, and we kind of look at that them in that model of whole health and try to get them to be taken care of on multiple different levels.
And I work in the veteran space a lot on this particular subject. I give speeches 5 or 6 times a year about things like suicide, moral injury, kind of runs the gamut of all the things that you would run into there. And the more and more I've studied this over the years and the more I've dealt with my own issues, the more it seems like we have a severe hardware problem, and especially amongst male veterans, where head injuries and toxic exposure have fucked up our pituitary system. We're not producing any of the correct hormones anymore, and then it's worsened by bad gut health from a variety of reasons, from poor food in the West to being in third world countries and shit. And these factors have all conspired to kill our natural production of the correct type of hormones. And I think it's a fact right now, and that it isn't even veterans only that are affected by this. it is widespread. I don't know about other Western countries, but I know in the United States, I've got the data on that, and it's rough. Like the numbers are staggering. The average 21-year-old male in America right now has the same level of testosterone that the 65-year-old had in 2000, and a variety of reasons for that. But it's a problem that's not like no major health organization is even looking at that problem. They're not paying any attention to that, and I don't know why. I mean, maybe it's just the anti-masculinity shit generally, but it seems like there's quite a bit of solutions that could immediately take place, like testosterone supplement or even just lifestyle changes that'll reboost testosterone levels that can fix a lot of this shit. Are you running into a lot of that? Like, what's your process? If some dude comes in and he says he's depressed, does it come up? Do you ask him about that, or do you test for hormone levels or anything?
I don't, because again, not I'm a medical doctor. However, with that being said, I will refer to the psychiatrist. I will look at some of the issues, making sure that they are seeing a primary care provider. Because one of the things with mental health is that you want to make sure there's no physical reason behind it
Sure.
before you spend all that time trying to do counseling that won't go anywhere.
Right. Yeah. I mean, well, so a primary care physician is going to say if you're anywhere in the range, then you're fine. So if a 25-year-old comes in who's just gotten out of the military and they're at a 370, they're gonna be like, "Oh, you're good. Go home." But they're not good. 370 is fucked for that age, right? And I ran into that problem. It took me, let's see, what year is that? Took me 3 years dealing with the VA to start getting treated for hypogonadism, like low testosterone. And finally I immediately started to improve after that, like my mood, physical condition, everything. And you're right. I mean, it is. There's definitely a place for therapy. I think it's good for people just to even just saying stuff out loud and hearing what you're saying is like showing your work on a math problem. Sometimes you're like, oh, that doesn't make any sense. Like that part of my epistemology is incorrect, and if I replace that with the correct answer, now I'm dealing with a whole different deck of cards here. So I guess that was kind of my journey. I'm curious though about what it is you do specifically. So let's walk through it. I'm a patient. I'm experiencing depression or post-traumatic stress or something like that. What's the workflow like that for you?
Well, I think one of the important things that I have that other therapists don't have, and I think it's 1/3 of the people that work like in the VA or something like that will be veterans themselves. But I am a veteran. You know, I've been in for 25 years. I joined when I was 17. I got trained at Blackwater to go and do some secret scroll stuff over in Iraq. So that was in 2008, 2009. So, I have some history that gives me the ability to kind of have that ability to communicate with some veterans that other therapists might not. That's helpful to have that in my background. So when I'm talking, I can speak the same language. I'm speaking and having a conversation with them. I can use the same terminology and it not be foreign to them. When they come in, basically, we ask them what the problem is to start out with. Why are they here? What are they looking for? What's going on that made them come in today, right? Because there's issues that happen all the time, but they came in today. So what is that issue? And then we try to figure out what's best to do with them in terms of dealing with that issue. So we have evidence-based therapies. We can do that long-term talk therapy if somebody comes in and they don't really have a goal. We can try to work towards that goal with more long-term therapy. But right now we're really focused on evidence-based treatments, trying to use what we know works to get somebody from where they are to where they want to be, meet their goals, and again, help them move on to whatever career or something that they want to do. So that could be cognitive processing therapy, cognitive behavioral therapy, EMDR, prolonged exposure, anything like that as far as trauma goes.
And so I've done CBT before, and one of the exercises was, I guess, exposure therapy is part of it, right? I wrote, and I don't know how it is for everybody. This is how it was for me. My therapist asked me to write down a particular let's call it traumatic experience, and then how I felt about it. And then we would go through and talk about it and stuff like that. And he would ask me how I felt about certain parts. And what I realized from that process, and again, this may not be the same for everybody, but I think that post-traumatic stress, in addition to the physiological problems that you're suffering, is, and again, this is just for me and a lot of people that I've talked to, it was more about the prolonged exposure to extreme stress than a single event. The single event just kind of becomes an effigy for it. Like, that's how I contextualize what I'm feeling. Like, oh, I feel hopeless and miserable because my buddy Zach is dead, and I had to watch that happen. But in reality, it's because it's a litany of reasons. My hormones are all fucked up. My amygdala is not operating properly anymore. My limbic system is all out of whack because I've been, like, my body has trained itself to be in constant fight or flight mode. So, you know, I found cognitive behavioral therapy extremely useful for that reason. And I feel like it's being undone, the idea of CBT, by just the promotion of catastrophizing in the modern West these days. Like, everything that's happening is the worst it's ever been, and it's also happening directly to me. And it's just not true, right? Like, some bill getting passed in Congress that doesn't affect me, like, people will cry in the streets and shit or protest, like, that has nothing to do with you. Like, what are you doing, man? Like, don't you have work to do? Like, something positive to make your life better and the people's lives around you better, other than to wail in the streets like that? But that's kind of become the standard lately.
Yeah, there's a lot of fear, right? And the fear that can help control populations and get people to kind of move in different directions. And I know that when we talk about different things like, harm reduction, abstinence is the way that people want to do certain types of drug interventions, like heroin and stuff like that. And you say, okay, let's try some, moving into trying to do Suboxone or needle replacement programs or something like that. And then, people will not have that, right? It's abstinence only. Otherwise, people are going to die, and they're just going to make them sicker, that kind of thing. And then on the smoking side, we do the same thing. We right now we, as in the government, I guess, they are pushing save the kids, right? The kids are having a big issue with the e-cigarettes and whatnot. But when we look at the statistics, they're actually coming way down, and the people that would benefit most, adults, are not getting the services they need through harm reduction because of this fear, the dynamic.
And so let's back up a second. Would you say that tell me about your feelings on needle exchanges and safe spaces for drug use and shit like that? I'm curious.
And the research has shown that there is a good, as far as harm reduction, as far as people not getting sick, not dying, these are some of the things that you can do. Of course, we want people to stop using substances that are harmful to them, especially like heroin. However, what can we do for those people that are not ready, basically, to make that step? And in terms of a harm reduction model, that's the idea, is finding the person where they are and help them to take that first step, whatever it might be, to make them more healthy. And if you get them to that one goal, then maybe we can get them to the next goal, right? So we kind of use motivational interviewing and motivate them to continue being like, yes, you did this. You took that first step. You stopped. You're coming in. You're doing what you need to do to get your needles and be safe and whatnot. So now let's look at what the next step might be, and we can keep moving them down the line, hopefully, in terms of that harm reduction model to get to a final goal, hopefully, which might be abstinence.
And how do you balance that with the negative effect it has on everybody else in society? I mean, like, LA, San Francisco, Portland, Seattle, all these cities are fucked right now because of, I would say, harm reduction policies have played a great role in how badly those cities are doing right now. So, how do you balance that stuff? Because there's also been some, I guess, noble efforts to some degree with Housing First, for example, or other situations that have completely backfired, right? I don't know if you know Michael Schellenberger, but he's done some pretty good work on that. It's San Francisco is the name of the book, and it kind of talks about that specific issue and how uh, uh, one or two additions to the program make all the difference. So they made in his study group, they made the housing dependent on passing drug tests, for example, and then people did quite a bit better. If there was no requirement for them to pass drug tests, housing first, they just turned it into a drug den and then burned it down and left, right? Eventually. So how do you balance that stuff? I'm curious, since you actually work in the field.
Yeah, I did a presentation for Partnership for Drug Free New Jersey about the intersection of opiates and this recently, and opiates and mental health recently. And the issue is that there are people that have tried quitting, right? That they've done what they could and failed and relapsed. And so we have these people that are constantly getting to this place where they're not able to be abstinent. They're not able to remove themselves from the dangers of that drug. And so what do we have for them, right? So either we can make them safer, and by extension, right, if they don't get the diseases that come with using intravenous, they can't pass them on, right? So if we can get them safer, then we can make the community a little bit safer as well in that way. Again, we want it would be great if they would be abstinent, but as far as what we can do is we can have them take that first step, right? That like, okay, you failed, taking that giant chunk, trying to say, yeah, I'm done, right? So let's take these smaller steps and see where we can get you. But we start where the client. We always start where the client is at that point, just to kind of get them to take small steps to make that goal happen.
What about ibogaine? I am familiar. Some of my friends own two separate companies actually that use plant medicines and stuff like that for a variety of reasons, right? But one of them, particularly ibogaine, I've seen this with my own eyes. Somebody who is desperately addicted to opiates go cold turkey after a single ibogaine session because it flushes your opioid receptors. I mean, I don't know how or why it does it. I just know that that's a fact. Has any of that came across your desk at all? I mean, it's kind of still taboo in the United States. You can only really do it in Mexico, Costa Rica, places like that.
I haven't seen that come across. However, what comes to mind is the psychological addiction, right? So there's the physical addiction, the physical dependence. You're talking about what's happening in your body, but there's also a psychological addiction.
Sure.
And this goes with the opiates as well as nicotine and whatnot. So we can get people to quit something quickly, relatively easily, maybe, given that one try. But like with nicotine, for example, there's an 8.5% success rate after a year of staying off of that of nicotine, right? If you're trying to quit, I mean, like 60% plus will relapse. So it's kind of yes, we can get them off the chemical part, the physical part, but there's something else that drives them back to use, and we really have to kind of figure out what that is. But if we could find something like the plant medication that we're talking about that would help that first part, that would be great. And we have to work on the second part.
And let's dovetail that back into the veteran thing. What about I don't know if there's an official phrase for this really, but what about the psychological addiction to war or to just being at a heightened level of adrenaline? I guess I don't know. What have you run into there? Because I feel like there's quite a few, like the physical addiction stuff it's not the same, right? But the mental or psychological addiction to being
Adrenaline junkies.
Yeah. I mean, it's very similar. It's very similar, and that's why I think we see a lot of dudes who go from, and it isn't just the military. It's action sports. It's fucking regular sports, stuff like that, and any kind of dangerous stuff. They just can't. They don't feel at home, calm anymore, and they've got to fucking be elevated all the time. Do you see any overlap there in your treatment?
Yeah, I see that all the time, and it's actually in terms of a PTSD screening. That's one of the questions that comes up. Do you do high risk behaviors? So it's a common thing that you'd see with PTSD. Generally, people that have been deployed and been in that situation. One of the interesting things is that there's also the other side, right? Is that after a while of doing that and maybe joining some paramilitary organization,
Mm,
FBI, police, paramedics, after doing all of these things, some people end up getting burnt out and then they get really depressed as
mm,
well. So you can see the flip side of that happen for a lot of people. But I've also, just in terms of the high risk behavior, I've had clients that have hurt themselves pretty
mm,
significantly, not purposely trying to hurt themselves, but in that whole process, and it just kind of complicates the whole clinical picture
sure.
with those veterans and whatnot. And I was a medic for 11 years, so I've seen both in the military and
Mm.
outside of the military some of the crazy things. I was when I was deployed. I was deployed with an infantry unit,
Mm.
and they were pretty. They drove fast in their up armored SUVs.
So you're like, were you in the Army or Marine Corps or
I am
Navy,
in
I
the
guess?
Army.
Okay.
Yeah,
So
Army.
you were a 68 whiskey back then?
I started as a 91 Bravo before they changed it over, but yeah, I
Oh
was
yeah,
a
okay.
68 whiskey
Yeah.
from E1 to E6, right? I
Mm.
was a non-commissioned officer, and then I went from for 11, 12 years, and then in 2012 I went over and became a behavioral health officer, and I've been a behavioral health officer since. And I just recently took over command of a medical transition unit, basically. So I help the soldiers that have medical issues that can no longer be in the military transition through the DES system, the disability evaluation system, into the next career, I prefer to say, but into the civilian world.
Um, that's interesting. So, thank you for being combat medics are the craziest motherfuckers that I've ever met in my life. Like some people think it's crazy to kick down doors and get into gunfights and all that bullshit and jump out of planes, which we did. I mean, it was fun. But it's fair enough. It's a little crazy, but running around with a London Bridge backpack on with 80 pounds of bullshit in it, and then setting your gun down in the middle of a gunfight to tend to some dude, that's a lot crazier than anything I've ever done in my life, to be frank. So I appreciate that. But I want to go back to this predilection that we develop over time, whether it's chemical, psychological, or a mixture of both, to be, let's call it a hard charger, right? How does the veteran that's listening to this that's still having a problem with that now, I guess, turn that into something positive? Because it goes one or two ways. It's high risk behavior, or it turns inward and becomes depression, right? So how does the veteran channel that into something positive in their life that benefits other people, I guess?
Sure. So there's two things I think I could say about that. One is to be able to gain control of it. So you have the sympathetic nervous system and the parasympathetic nervous system. And what I'm just talking about is the
Mm,
fight or flight response,
mm,
the thing that keeps you moving, and the opposite, right? The thing that calms you down. So one of the first things we have to do is be able to calm ourselves down and train the relaxation response, because we don't. We're veterans that are those hard chargers. They're on they're stuck on fight or flight all the time, right? And I'm not saying that in a bad way. It's just they're tense and ready to go. So they need to take their time and figure out a way to train the parasympathetic nervous system to that relaxation response. And although some people, some of the veterans might be like, no, I don't want to do any of that breathing stuff.
mm.
Meditation, deep breathing, all of that stuff is really important for that aspect of things.
Well, yeah, I mean that's
On the
super important though, at actually not just integrating back into society, but being good at your job while you're doing it is one of the main things. Well, I guess two of them, but I think they relate really closely. Is staying calm under pressure and then being able to burn cortisol at a quicker rate. And that's what some of this breathwork stuff or some of the meditation stuff can actually do for you. Now, there have been studies in the last 10 or 15 years of what makes special operators unique to their job, to the military in general, and then to the broader public. Excuse me. And one of the primary things, as a matter of fact, I think the largest separation between them and any other group, and when I say separation, I mean things like muscle mass, cardiovascular fitness, blah, 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 right? Just hand-eye coordination, eyesight, all the stuff that would matter in a combat situation. The rapid burning rate of cortisol is one thing that sets them apart from everybody else. So you can actually train your body to do this, not just with good diet,
Mhm.
which that does help, but some of these it doesn't have to be breath work, but some of these meditative techniques really help with that. So I would say it isn't just a treatment. It could be a prophylaxis as well. Not even just a prophylaxis, but something that makes you better at your job while you're doing it. We don't do any of this shit in the military. Like when you show up to your unit, you go to basic, you know this, you go to basic, get all your training, you go to A school, get all your training, you go to your unit, you get a bunch of different training. They're like, this is how we do things here. Not once does anybody ever tell you how to handle yourself as a human being, right? Mm-hmm. How to get better mentally at your job. Now, I've never heard anybody talk to me about that in my 5 years in the military, in the infantry, right?
They have now from UPenn the positive psychology movement, that push. They helped develop the Master Resiliency program, which is based off of cognitive behavioral therapy. Mm-hmm. I think that's just one attempt at doing this, is to kind of be able to bring stuff back a little bit and teach people how to again be more resilient as they're doing this stuff. But you're right, the idea that we can use this, and it's not just a thing that we want to do to kind of calm ourselves, but we can use this in those moments to help us be better at our jobs, is something that I actually do in therapy a lot. I call it enveloping. I don't know where I got it from, but it's probably not my term. But basically, when somebody comes in and we're about to work on something difficult, we will use a breathing exercise to calm them down, and then put them into the stuff, and then use a breathing exercise at the end, so that we can kind of get them in the right mind state to be able to do that.
I mean, I bet it's a lot easier sell for somebody like myself, who was an infantryman in the 82nd Airborne, to be like, hey, we're not going to dull your senses. We're going to teach you how to use them better, right? Like, tune out all the static and the noise and get down to business. Which is super helpful. Like, because I don't want to, I don't want to walk into a room and not be fully aware of, threats and exits. That's something that I want to be able to do. But I don't want to be paralyzed by it either. You know what I mean? Like, you still want to be able to enjoy your life. And I don't think a lot of people come out of the military thinking a bunch of different weird shit. Like, I'm never going to be good at anything again because I was so good at this, and this is one of the hardest things to do. How am I ever going to use these skills again? Blah, 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 right? But all the skills you learn in the military, whether it's some technical proficiency or anything else, are going to be useful no matter what you do for the rest of your life, because you can do shit that other people can't. You can fucking have a conversation during a gunfight. People can't do that, right? So you just got to figure out how to do that in a way that doesn't, I guess, interrupt or marginalize all the other functions that you're doing. And that's what separates, the casual gunfighter, if like myself, from somebody that's a serious operator, right? I mean, and that's really what it is. It's all in the head. It's all in the mind. So I feel like this stuff is super useful. And telling somebody that you're going to help them hone instead of dull their skills is probably quite a bit more acceptable to these dudes, I would imagine.
Yeah, and I mean, they don't believe it at first, but after a little while, they if they buy into the program and are able to kind of work with me or work on themselves, then they come to the appropriate conclusion, hopefully, that this is something that'll work for them. But it is literally something that I have to say quite often, is that this, the process that we're going to go through isn't going to take anything away that you actually need. It's just going to take away those things that are disturbing you, distressing you, as much as we can.
Sure. Yeah. I mean, I'm not going to take your hammer away. I'm going to teach you how to use it better, I think, is a good way to think about that. Because that's like, to be honest, I was very reluctant to get any kind of treatment, whether it be physical or psychological, for that reason. Like, I was like, this is who I am. I'm like, the world is a dangerous place, and I want to be dangerous as well. And that was a huge barrier to entry for me to get help. Was like, I don't want to fucking be some bump on a log somewhere, which is I think it's a good instinct to have, because it keeps a lot of people off pills, because the VA especially likes to just like hand you some pills and be like, all right, good to go, bud. Yeah. I mean, it's gotten better. It's gotten better now.
I talked to one of the psychiatrists recently, and they're like, I don't like to be called a prescriber. I do much more than that. I'm like, well, there are a lot of psychiatrists out there that seem to be really just into pushing the medications. So, it's really good to hear that, you're doing more than that, and you want to do more than that. But it does seem to be a common practice at this point to prescribe lots of meds. I usually ask people three questions in terms of their meds. One is, are you using it because things are coming through the walls, right? Then you need it in order to
Yeah.
function.
Yeah.
Two, you need it for therapy, right? You're too hyper aroused or even hyper aroused. You're too up or too down to really appreciate what we're talking about in therapy. Or third, you've gone through therapy or you didn't need it. You're able to function. Life is great on the outside, but on the inside, you just need something to improve your quality of life. Those are the three reasons why people, I think anyway, should take medications. And if it's not doing that for you, then you have to have that conversation with your doctor. Right? This is not what I expected.
Sure. Let's talk about EMDR and what it is. I've gone through it before. Let's see, what year was it? 2013 and 14, I think. For about 8 months. Very helpful.
Wow.
It was helpful. The explanation of it for me was actually more helpful than doing it, because my brain figured out what was happening and it just kind of adjusted on its own. And maybe that's the case for a lot of people. They just don't realize it's happening, but you still have to do it. But explain exactly what it is to people and how it helps people, especially who have broken sympathetic nervous system, amygdala issues, all that stuff, limbic system issues.
So CBT is like a top-down approach where you have to sit there and you have to think about things in order to change your thinking about them. With EMDR, what we're trying to do there is to avoid that piece where you don't have to think about things because they don't come up anymore. So when you have a memory that is distressing, most of the time, or often rather, we push it in the back of our mind. We don't want to deal with it. And so because we do that, it's stored raw. It's stored with the same thoughts, feelings, physical sensations. Any of that stuff is still wrapped up in it. So if anything happens, triggers it, a lot of that stuff will just come out. And then you start having problems at home, at work, etc. So what we try to do with EMDR is change how that memory is stored. So we do BLS, which is bilateral stimulation, or dual attention stimulation, depending on who you talk to. And basically, one of the theories or ways that it's described is that it taxes your working memory. So you can't be sitting there and be distressed about something and also thinking about this thing being waved in your face, or the physical sensations if you're tapping, depending on what you're doing. You can't do both. And so the distress starts to come down a little bit. And if you keep doing that and going back to the memory, the distress will keep going down. We're hoping to get it to a zero, right, where it's neutral and the distress just doesn't come up anymore. On the plus side, when the distress is gone, all of a sudden you can think about it, right? Before you couldn't think about it because then you'd have a reaction. So now you can think about it. And so everything that happened from that incident when you had that trauma and to where you are today can finally weigh in and be like, I was 15, I was 16, I was a young kid then. I don't believe that now, right? You didn't have that chance up until this moment. So the brain gets to store the memory differently with less distress and and more adaptive thoughts attached to it. We call it the AIP model, right? The adaptive information processing model. So this new adaptive information kind of helps you process and feel differently about the memory.
So is it primarily about exposure therapy to lessen the effect of the stimulus reaction, or is there anything in EMDR because this is kind of one of the things that plant medicine tries to do, is to reroute neural map, right? So like, excuse me, a certain stimulus in your life, a bright flash of light, a noise, door slamming, whatever it is at this point endemically associated in your head with a certain outcome that is negative, right? Like a gunfight or a bomb or whatever the fuck, right? It doesn't matter what it is. So anytime you receive that top of line stimulus, you're going to react as if you're back in that situation. And one of the things that plant medicine helps to do is to I think of it as redrawing the roads on a map, right? So instead of that stimulus automatically being that, maybe you put a buffer in between those two things, or maybe it routes to something entirely different, right? Is there anything like that in EMDR?
Yeah, one of the good things about EMDR versus another exposure is that you don't have to stick with the memory. You actually let your brain make it. It's a free association. You make your brain allowed to go and make other connections. And you play Jenga, right? You have the things all stacked. We usually start with these memories that are really bad for you, like that your triggers are up here. The bright light that comes up that reminds you of something. Your triggers are on the top of the Jenga board. What we're doing is pulling out these memories at the bottom of the Jenga board, so that when we get up to the triggers, there's nothing really holding them there anymore. They're not attached to what happened in the past anymore, because those have been desensitized. You don't feel bad about those. The stress doesn't come up. What we have to do is work on secondary conditioning, which means that now these bright lights, now these triggers, they're triggers in and of themselves, right? They're not attached to anything, but they still bring up the stress. So at that point, we work on them a little bit. They usually go away pretty quickly, and the person feels a lot better, and they're not triggered by these things. But as far as the neurological thing goes, what we say is what fires together wires together. By having your brain do this free association exercise and fire with these adaptive thoughts, like, oh, I'm 40, I'm older now. I'm an adult. I have a better way of thinking. When you have that adult perspective firing with this, triggering memory back here, then that's going to change how that is physically stored in your brain. That's the theory, anyway.
Well, I mean, like water eroding, like a tributary, for example. The longer it runs, the deeper it gets, and the same thing is true of your memory. So I would imagine that consistency is going to be a big part of this, like doing it, like really getting into it and doing it on a regular basis over and over. It's not something where you're going to show up to cognitive behavioral therapy once and like, oh, I'm all fixed up now, right?
The original research, if you're doing this on one thing, right, you had a car accident, there's a good chance that within a couple of sessions you won't need to come back, right? But if you have complex PTSD, if you had childhood issues, and then you also had a car accident, and then you also went to Iraq, Afghanistan, there's probably going to be some more time that we have to spend working on all the different things that are interconnected in those types of settings, in those types of presentations.
And for people who are, I'm trying to think of a good way to ask this question. If somebody is listening to this and they're wondering if this might be a benefit to them, are there questions they can ask themselves that would be like, yeah, it's time to reach out to Dr. Vermillion about this?
Well, can they do homework? Right? So you've done CBT, it requires some assignments, right? So if you want to do that, if you're more intellectual, if you say, I want to get down and dirty, and every day I want to start writing stuff out to really focus on what I'm thinking and how I can start moving forward, then you might want to do CBT. If you have tried CBT, or if you don't have that ability to concentrate, then you might want to try something else, because EMDR doesn't require homework. You don't have to do something each day to kind of make EMDR work. It works without all of that extra energy. And one thing about EMDR that's also positive, you don't, especially for veterans, you don't have to tell me anything. We can do this blind. I just need you to know what we're talking about, right? So I need you to give me some kind of landmark. So, a phrase that I can use that will bring up the memory for you, but you know what that means. I don't have to know specifically what's going on. So this is great for people with sexual trauma, as well as people that secret squirrel stuff. So that's like a big piece for veterans, that they don't have to tell me the specifics. This will work without the specifics.
Sure. We've also got a pretty big first responder community in our network here, and I wonder what are the big similarities and differences you see between those two communities? Because I feel like it's different to be under constant stress in a combat zone, and then be a cop or an EMT or an emergency room worker or something like that, and then be consistently exposed to fucked up. Like I could go a month, 2 months, 6 months in a combat zone. And yeah, we get into gunfights and shit blows up sometimes, but none of my buddies die for that amount of time. It's like that happens sometimes. But I think EMTs and emergency room workers see more fucked up shit than anybody. Or even, I guess, maybe not the combat medic, but the medic in the hospital, right? In the Ford operating hospital is going to see a lot of, like, a pretty consistently. But the difference for EMTs is I go do my 10-hour shift. I see some just truly horrible things, and I'm in my own bed that night. And then I'm
Mhm.
back seeing horrible things, and I'm in my own bed that night. I wonder what the similarities and differences between those two communities are, because it seems like there would be some overlap, but it also seems like it might be quite a bit different.
Yeah, so I've worked with EAPs for sheriff's offices and stuff like that. I do see people from that. I do see those patients as well, and there are a lot of similarities. One of the things in regards to like working in a hospital and stuff like that is that you will have those moments when something is overbearing or overwhelming. However, people get used to it. It's their job. They don't get traumatized by some of this other stuff. They don't see the person anymore, which is unfortunate for sometimes for the patients. But they see the problem, and that kind of helps them be able to do some of the work that they need to do. But when they go and see something like children or something like that takes them out of just that piece where they can look at the problem, then there might have some issues that we have to deal with. Or when police officers are responding to something and they feel like they didn't do something they should have and something bad happened, then that's another issue. But generally, they can go through and feel confident in the things that they did do. So that's, I think, kind of the big piece with the first responders is that they're used to their jobs, and they've been able to mentally figure out how to point themselves into the work that they're doing. And then there's just those moments of overwhelm, which end up having to come see me or somebody
Sure.
like me.
Yeah, it's good information. So one of the things that concerns me is what I mentioned before is catastrophizing, and it basically is the opposite of CBT, right? CBT teaches you to process things and contextualize them. You're like, all right, cool, that's something that happened, but it isn't my identity. I think that's a big part of it. And catastrophizing, which is often it's taught in the West as a part of our infrastructure now, in that people are encouraged to view their lived experience as the only reality that matters to them. And I think that is a silly way to go through life, frankly. But it is true, right? And many people have written about it. Jonathan Haidt and Greg Lukianoff wrote The Coddling of the American Mind. Is a very good book on that subject.
Mm-hmm.
I wonder, from your perspective as somebody who's, an expert in this field, for people that haven't necessarily experienced traumatic events, or who people who are raising young kids to teenagers and trying to make them more resilient in the world, what are some of the benefits of, let's call it like light cognitive behavioral therapy, like taking the lessons from that and weaving them into the way you mentor and parent and even lead at work and things like that?
Yeah. So when I do work with people with cognitive behavioral therapy, it's one of the things that I do use as well. It's one of the conversations I do have is at the near the end. I'm like, when somebody comes at you and they're upset, just like we've talked about you and what happens when you're upset, how, where your mind is going and what that all means to you. This is the same thing that's happening to them. So one, you can be less defensive because you can understand that this is their stuff and not yours. You don't have to take it on you. So, you can let them be upset and let them be upset because of their reasoning and their interpretations. And then we can also discuss, and this is something that you can teach other people as well. I wouldn't go to your significant other and be like, well, you're thinking wrong. Probably won't work out for you. However, your kids might benefit from that, having that conversation, being able to bring up, those thoughts, what you're thinking, and be able to kind of move in that direction. So it can be very helpful. And it is something that I do push when I'm working with CBT with clients.
Sure. Well, give me like a practical example. Somebody's got a teenager, and the teenager is like, I don't know, things get to them. They're affected, right? They have an affected personality, and you're trying to kind of work that out of them. How do you have that conversation? I know this isn't like talking to teenagers, probably isn't your expertise or anything, but like, what would be some advice you would give to somebody in that situation to kind of like, or I guess if you were talking to the teenager, what would you say?
I would say I would start with the idea that let them be angry, right? So
Mm,
that's the first piece is to recognize that they're angry. Don't be defensive, right? Because that's the thing that's going to ruin everything. It's going to make it so that you can't talk to that teenager if you start being defensive, right? So you can be calm and be like, listen, I can see that you're angry. Just let me know when you calm down,
mm,
right? Or we can talk when you're a little bit calmer, right? Something like that. But don't be that defensive in regards to it. And then when they calm down, you find out how what was making you angry. What was that? What were you thinking? What was going on through your mind that was bringing up this stuff for you? And then when they bring that up, you can say, "Is there any other ways to think about that?" Something like that. It's basically doing CBT with them on some level, and without going into the specifics of the problems of problematic thinking or
mm.
something, you can kind of get their appreciation, help them find an alternative way of looking at things, and then maybe even practice it as you move forward. And that also kind of lets that teenager know that you're somebody to talk to that
Mm.
won't come at them and judge them and fight with them
Sure.
when they're upset.
Yeah. I mean, that's got to be tough to balance being the person in charge with being a person that's trying to be empathetic and understanding and shit like that. I don't.
Balance. You don't want to be that friend.
Yeah,
Yeah.
yeah. I mean, I don't know how I'm gonna handle that eventually. We'll see, but I'd like to think I would be good at it. But you never know.
Mm-hmm.
So, what made you? I guess your parents were veterans, so you decided to join as a medic. What made you decide to go in as a medic?
I mean, I've always been wanting to help people, even now. Like, I want to help the warfighter and stuff like
Mm,
that. So everything I do is kind of like in service to somebody else. Don't know why where that came from, but it is just something that drives me. How can I help people in different ways? And again, I've been in the military for quite some time. Um, and in 9/11, I was in Fresh Kills landfill
mm,
doing where they brought all the debris and stuff.
sure.
And even my commander at that point, was having an emotional reaction based on everything that was going on, and had to kind of talk to them down at that point. So, there's a lot of stuff that happens, and as a medic, you can be there for that. So it's not just the physical, but also the psychological
Mm.
piece there.
Yeah, and then what made you decide to, I guess, leave the groundwork of combat medic to go to something more advanced, I guess?
I was just going to school. I go to school forever.
Mm,
So I was, getting that master's, and then I got a direct admission. Is really what it comes down to. It's like, okay, I can take this and I can move forward and be a behavioral health officer. Continued working with people and for people and serving people, just in a different way, and kind of took that path.
and what do you see coming down the road? Like, just out of curiosity, in the psychology space, or uh, uh, what are there new methodologies coming, or are we just kind of refining old ones, or how's that working right now?
I would say that we're always going to be refining old ones. There are some of these things like the psychedelics and whatnot that come up, and there are some benefits to that. If it worked perfectly, then everybody would be doing it. They would have
Mm,
moved to that, but obviously it's not perfect. But that stuff's been around forever. I mean, it's just now we're bringing it into the more professional realm. But using psychedelics to help people with their mental health has been around for a while. Um, so that's on that side. We could talk about again harm reduction. We have the smoking cessation methods that we have. We have all the medications, all the nicotine replacement therapies, but
mm,
people they keep on relapsing. And
sure.
so you have the e-cigarettes, which is 95% healthier. So, we can get people to, Nancy Rigotti, who's a Harvard researcher, she just kind of talked about this last week on briefly on a webinar. She said, if you can, she agreed that you can get people to switch immediately from cigarettes to vaping, and that would be enormously helpful as far as their health, and then do the counseling or the medication. They're talking about a new medication that they're trying to bring over. But you can get them on the new medication to come off of that if they wish to, right? So it's kind of like a path thing. But the first thing they want to do, get people off cigarettes, and they were talking about e-cigarettes. e-cigarettes as being one of the primary ways to do that.
So somebody that smokes and is looking to stop, what advice do you give them? What resources are out there so they can learn more about how all this works? Because I think you said, what was it, 8.5% is the success rate for just trying to quit smoking, so not very high. What are some things people can do to make that success rate a little bit higher?
Well, I mean, the first thing, and if we're going to talk about saving lives, right? If we're going to talk about the best thing that we could do in our lifetime for public health, individual health, it is probably to get people off of cigarettes first, right? Smoking is what kills you. Nicotine does not. In the VA, if you download their little workbook for smoking cessation, and then you look up the nicotine piece, it says that nicotine is not bad for your body, right? It's the
It's a
everything else
nootropic.
that comes with it.
Yeah.
Yeah, everything else that comes with it, right? So we need people off of smoking, and we know that e-cigarettes, also the pods, right? The pods are even better than e-cigarettes because the pods have less stuff in them. But these alternative ways are not promoted in the government and the VA and stuff like that. But if you keep failing, one of the first things we want to do is get people off of the cigarettes. Matter of fact, they say 70% of veterans want to quit smoking. What about the other 30% that don't want to quit smoking or don't want to quit nicotine? Maybe we can get them to move off of the smoking to save their lives, because 480,000 people die a year of some type of smoking-related illness. We need to do all we can to save their lives.
Great. And is there like a resource online somewhere other than the VA that they could go to that has information about this stuff?
Yeah, the VA is huge. As far as veterans go, I know that they have smokeless vets. They have this mission to get 50% of veterans off of smoking by 2025. So they're a good organization right now. I went down to Nashville and did a presentation with them fairly recently. So if you want to, as you're a veteran, if you want to kind of look at that, would probably be one resource. And they speak the truth. You'll see some videos on there, and they really kind of get into what the expectation is in terms of smoking and what we need to do to become a smokeless society, like Sweden or something.
Sure. All right, great. Well, look, appreciate your time today. It's been a really interesting conversation. Hopefully people got something out of it. You do remote counseling as well. So tell everybody where they can find you and if they are looking to get into some of this stuff.
Sure. If you want to find me, you can find me on Dr. Vermillion on Twitter, or you can go to drvermillion.com, which is drvermillion.com, which is my clinical website, and we can kind of touch base there. And again, whatever you want to talk about based on what we've had a discussion with today, I'm more than happy to continue the conversation.
Yeah, 100%. And keep in mind, for those of you out there that are looking for some kind of counseling like that, he is a combat medic, was a combat medic, so he's, he understands some of this stuff at least. So again, thank you for coming today. I really appreciate your time.
Thank you very much.
Yes, sir. And thank you all for listening to this Citizen.